thanks so much, John, and for the lovely gift, and actually all the organizers and everybody for having me here today. It's been a fantastic opportunity to come and see this. The meeting yesterday was amazing to see aeromedicine in Canada coming together and advancing like this, and it's been a pleasure to meet so many of you. A couple of things to start off with this talk. First off, the service that I work for and I'm about to tell you about, London's Air Ambulance Service, is not perfect. Every service has its problems, its issues, its growing pains. There are days where my hair is getting grayer than it is right now. There's other days where I would never change what I'm doing in the world for that moment. So that being said up front, just so you know, I've never met the perfect service. I would love to take the best of London, the best of Orange, the best of what I'm seeing here in BC and put it together in a service one day. The second thing is that I'm going to steal a little bit of Mark's introduction to his simulation talk, because I didn't do the pro-con debate about physicians and helicopters and stuff like that, probably because my blood pressure would be up too high. I'm going to use the beginning of his talk where he said, if you've seen simulation and experience, I'm not going to tell you all about it, just know that it is the right thing to do. And I think that is the case. Critical care paramedics in Ontario, and I'm sure from what I've seen here in BC, are absolutely amazing. What I want to challenge you to think about is the level of care we could provide if we even work together to bring physicians and critical care paramedics to patients like that woman with a bleeding spleen in northern BC, and how we can make a difference to save lives together. That would be a service which I think is untouchable in the world in terms of quality of care and class. So it's not about one versus the other, it's about coming together and doing amazing things. So a little bit about the why I did this. So why did I leave a wonderful sort of cushy life in Ontario and being paid nice Canadian physician salaries to go work in England and live in London where you can not save a thing, and life is wonderful living there, but quite difficult. So the story actually starts back, I think it was about 2012 or 2013. I was in London for a different meeting, something to do with the World Health Organization and Wellcome Trust that I was invited to. And I happened to notice there was this conference called the World Extreme Medicine Conference, and if you haven't been to this, it's something to look up. Some great knowledge and information exchanged at this conference every year. And they had a pre-hospital day, and I was a transport physician with Orange at the time, and I thought, oh, I'll go see their pre-hospital day. And I went there, and I was a somewhat slightly jaded intensivist who'd thought, things about traumatic cardiac arrest, and having been a paramedic, I had very firm opinions about the roles of physicians in the pre-hospital setting, and I definitely wasn't an advocate of that at the time. And I went to this meeting and I sat there, and there was this kid sitting next to me for the whole day, wearing one of the London Air Ambulance shirts, and I thought he was a medical student volunteer or something that's there for the day. And had a few conversations, really nice. He was just finishing his first semester of engineering school and was really just a great kid. But then at the last lecture of the day came, and I realized that the guy who was sitting next to me all day was actually down at the front of the stage there. And it was Gareth Greer, who's our lead clinician now, up there speaking about some of the innovations that they're doing, some of the stuff I told you about today. And this guy, who was much younger at the time, this is a picture from just a couple weeks ago, was standing there. And then he lifted up his shirt and showed his thoracotomy scar. And he was one of the first survivors of a left ventricular stab wound in the world, actually. And at that time, he was in his late teens, literally wrong place, wrong time, stabbed dead on the scene when the team arrived, did his thoracotomy, and then like 6 months later, he's just finishing his first semester of engineering school. And that moment, and after hearing what I heard about the team for that day, I decided I had to go work for them at some point. And this is him just recently at our 30th anniversary party, and it's amazing. And the number of people like this that I've met, and the number of patients that come back that I know absolutely in systems outside of the UK, and certainly patients I've experienced here in Canada would not have survived. So that's what is the why I did it. The second thing was that I spent a lot of my time in my career teaching simulation, talking about human factors, patient safety, quality, CRM, and I realized that this was an opportunity to truly join what is a high-performance team, and to actually go and live this every day and see what it was like in a way that I had never experienced before. And it was a personal challenge to go and exist and belong to this and learn and see if I had what it takes to belong. So that was really, for me, was those two things that caused me to go there. So the how or what is it that we do there? So what we do is we provide service to the patients in the London area. A couple of things that are important for setting the stage and understanding is that you'll notice, we just have a new logo up at the top here, but at the bottom of the logo we've added charity, because all the air ambulances in the UK are charities, which is very much a strange kind of system. When I first got there, I thought it was very bizarre because it's very unlike the system here in Canada. But it's sort of a British cultural thing that the RNLI, which is the Lifeboat Rescue Service, all of the search and rescue services, everything that's sort of a rescue kind of service in the UK is charity funded. And it's just the way the system's been set up there and it's continued to run. I do recognize now that it actually offers us a lot of opportunities because we're able to innovate and do things in a way that we would never be able to do like if we were a part of the NHS. Because when you're such a small little bit of a large organization, even though you make a critical difference to those small number of patients that are in that very high end of trauma that survive, in the big picture of spreadsheets and things like that, it's hard to sometimes notice. So our service is run with a tripartite organization. So we have the charity, which provides the money and the funding for all of our operations. We have the London Ambulance Service, which provides our paramedics, and Barts Health, which provides our clinical governance and all of our doctors. And so together in this tri-party organization, which is at times interesting and one of the struggles and frustrations, I don't know if you've lived much of your life in a threesome, but it does get to be a little challenging. There's often one partner that's jealous and not talking to the other partner. So it does keep us, it makes it interesting, especially for us minions that are sort of the one rank below in the HEMS clinical board, that the leadership team that I sit on that sort of runs the day-to-day operations as opposed to the big wigs. So that's how our system is set up. What we do is, and similar to what we do here, is we bring an advanced trauma team, basically the ICU and the intensive care and the trauma room, to the roadside. And that's pretty much our mission. Our vision is to end preventable deaths from life-threatening injury in London. Our mission is to save more lives in London through rapid response and cutting-edge care. So see, cutting edge was in there, that's probably where you got it from. And our values are to be compassionate, courageous, and pioneering. And those are all quite interesting, particularly the pioneering one, because if you understand the history of HEMS in London, they actually spent about the first decade or so of their existence really fighting to stay alive because everybody was constantly trying to close them down. They thought there was, from all different aspects of the medical community, whether it was the surgeons, trauma surgeons, physicians, paramedics, everyone just was trying to get them. So they were pioneering. They had to push the limits or push the boundaries, and but over time, I think that's proven the benefits and their strengths. Our long-term objective is to deliver the best possible service to London, in London, to everyone who needs it, when and where they need it. So that's really what we're striving to do. We may also be the first HEMS service without a helicopter. That's one of the innovations that we actually consider on a day-to-day basis, given how we operate. We need a space about the size of a tennis court to land the 902 in, which in London with real estate prices are getting fewer and fewer and fewer. And houses with tennis courts often don't let you land or like you landing in them. Although we do have our welcome guests at the Buckingham Palace and the other palaces, I can give you the gate code for the back gate of Buckingham Palace if you want to get in or out someday. They treat us pretty well. We get to land in interesting places like Trafalgar Square and any sort of big flat place. But we do a lot of running because it's getting harder and harder to land close. And then at night we operate by rapid response car because we can't do NVGs in London, so there's just far too much light pollution. Across the rest of the UK, most services have moved to night vision goggles and NVG landings for night operations, but it's never going to be feasible for us to do that in the city itself. But luckily traffic is slightly better during the day, so we have these rapid response cars, which we actually put all of our paramedics through an additional very intensive driving course, and we have a driving standards manager, and we have some interesting rides. The doctor's job is to navigate, and we use a system of navigation which is similar to rally car driving. So basically one person is just driving, the other person is constantly feeding them directions, step-by-step directions as we go through at very high pace sort of intervals through some of these streets in London. Our team consists of now generally 2 doctors, a consultant level doctor and what we call a registrar, but are often consultants from around the world that have come to work with us, and a paramedic. When we have paramedics in training, then we have 2 paramedics and a consultant level doctor. We moved to that 3-person team just this past year because we just see that the amount of intervention you're doing when you're trying to do a thoracotomy, get a central line in, have an airway managed, have scene management, you really need a 3-person team to effectively get this done in the time that we do, because this is not a stay-and-play service. We constantly look at our scene times and get pushed, and I can tell you that we actually, very often when we arrive, we actually speed the scenes up and patients start to move faster with the things that we bring, particularly things like early sedation and to facilitate packaging and movement and getting scenes going. So it's not sort of the stay-and-play kind of service. We're supported by, we have 2 pilots on the helicopter, and then we have a fire crew and a number of other support services back on the helipad to support us. We have a helicopter at all right now because of this figure down here, which is the average traffic speed in London. So it is, London is a city that burned down a number of years ago, and they had the perfect opportunity to put a nice bridge system in that would have been effective and efficient, but they made a decision not to do that. So traffic just doesn't really move in London that well. I cycle everywhere in London and get everywhere faster than I could ever drive. So we really need this to be able to get to the just shy of 10 million people that we service inside the ring of the M25. Otherwise, it would be very impossible to get our teams to the patients. And really, we operate in a model where the helicopter is there to get the team and the equipment to the scene. I'll tell you in a minute about bringing patients back. Our call volume sort of average sometimes, and usually range somewhere in the sort of just shy of 2,000 patients treated a year. For this past year, unfortunately, for the first time ever, penetrating trauma and stabbings were our #1 cause of patients. And we've treated just shy of 40,000 patients over the last 30 years. So this is all part of an integrated trauma system, the London Major Trauma Network. So level 1 trauma centers in the UK are called MTCs, Major Trauma Centers. So we have major trauma centers, and the other hospitals are called trauma units, or just non-trauma units. They don't take any trauma. But predominantly, we go to one of 4 hospitals in London, and you can see that if we fly from this hospital here, the Royal London, to other areas, often we can get there faster going back by car than if we go by try to load and fly back and all that stuff. 3 of the 4 hospitals, Royal London, King's, and George's, all have helipads. St. Mary's currently doesn't. And the in-hospital trauma system is actually still something that's quite new, and it's just been developing over the past less than 10 years in the UK. So in-hospital system in terms of the trauma care delivered to the Royal London is, I'd say, second to none in the world. But the actual overall system approach is a relatively new thing, and they've learned a lot from North America. So we also have something called a physician response unit, and this has been around in evolution for different sort of types in the past few years. This is a physician, and then what would be like a primary care paramedic team that go out. And this is, it started off a long time ago. It used to be staffed by the HEMS doctors and HEMS paramedics, and it started off as the cool car when we were doing therapeutic hypothermia for post-cardiac arrest and whatnot. Now it's evolved into more of a community emergency medicine. So it's really about bringing the sort of emergency department level skills of patients, trying to not really avoid admissions because they don't like talking like that. It's about getting care in the right place at the right time. And they really facilitate a lot of patients. They also have a nurse that works with them and does a lot of the matching in hospital. The physicians that staff that are more junior than physicians that would be on the helicopter. And the paramedics, actually, it's an amazing sort of opportunity for the PCP paramedics that are on it, because this is a highly sought after opportunity for education, training, and advance. And then so many of them, both the doctors and paramedics, often go on to become our HEMS doctors down the road. So it's a good sort of development type of tool. And they're expanding. The data show that they've saved millions of pounds in the past year, and they're looking at double or tripling the number of cars. They now operate 12 hours a day, 7 days a week, but they're looking at putting that up to certainly 1 more car starting, and possibly a 3rd car starting in the next couple of months. So in terms of what's different, so one of the things that are the insights for this for us. I know we all care about patients, and you hear that all the time in different hospitals and healthcare organizations' mantras. But there is a difference that I've experienced in this organization where literally every decision, everything we talk about starts from the patient and focuses back to how we can optimize patient care. And I know during the debate I cringed a little earlier, and Mark, I'm sure you may have said this in jest, but a concept such as to defend a developing profession is something that would never even enter into the lexicon of this organization, because it's not about us, it's about the patient and what we can do for that person. So I think that's one of the things that really attracts me and drives me. We have a lot of interactions with our patients. We take a lot of guidance in terms of looking at how we can continue to improve from our patients, but this is what gets us all through every day and the things that we do, and is the focus of all the decisions we make. In terms of being a highly reliable organization, this is one of the things that's quite interesting. This is work that's been done by KPMG a number of years ago, looking at hospitals and error rates, and basically a description of the organization and how you sort of move from being really healthcare as an art with the artful masters having complete autonomy. You know, you decide what you want to do in terms of what drugs you're going to choose, how you practice medicine, all those things, through to, on this side, going through past the constrained collective into teams with strong situational awareness and all the sort of human factor side of things. And this really is one of the areas where it's one of the few organizations I've operated in that really exists out in this side. And that is a change. So it's a change that you have to accept when you sign up to the organization. It's kind of like, I think, you know, one of the things that I showed a picture of the race car earlier, could be a rowing team, maybe a better analogy, because you have to accept that you're going to give up individual liberties and freedoms as a practitioner to be part of this organization. That's true whether you're a doctor or a paramedic, that you will sign up and you will do things the London Hems way. And there's a way that things are done like that. And it's not that we can't still innovate, it's not that we still don't think on the scene and stuff like that, but there is this collective sense of, we do this way because we know this improves the outcome for the patients. And if you go off script, you have to be expected to explain yourself and have good justification. We'll have a conversation, and we have lots of conversations about why you did this. But there's that thing of getting people to accept that you're going to control a little bit of freedom. And I remember a while back with Orange, we were having a discussion about even RSI drugs and stuff like that, trying to get all the docs in the room to agree to a standard regimen for RSI was, you know, a challenge, let alone actually being out there living and doing it. And like I said, we have SOPs for everything, but they're SOPs that really force you to think and ask questions, and they're not cookbook medicine. They rarely give you the exact answer of what to do, but they're the best, they're the history and knowledge of all the people that have been passed down through the organization, all the lessons learned, all the errors in the past and mistakes that have been made get incorporated into these, so it helps give you a guide as a person when you're dealing with that patient you may have never seen before, how to practice. We have checklists and stuff that you're talking about yesterday, but even kit checking. So you can walk into the base and every day, all of our teams, and again, whether you're a consultant, a registrar, or a frontline paramedic, you have a list of kit that you're going to check that day. And we do that for a few reasons. One is that all of our kit is always checked and tagged against standard checklists, in part because we have a strong belief that that is critical to freeing up bandwidth when you're on scene. So that you know if you reach for something, it will be there and it will work and it will be in date and it will be ready to support you and be able to help this patient. The second thing is there's no way to learn kit by checking it, other than checking it. So when you've checked the Thomas pack or a primary medical pack again and again and again, you know, you can go through and recite what's in any pouch of that. And when you're on scene and when things start to get hairy and you start to sort of, you know, you're trying to deal with a very, very sick patient, you don't have to spend brain power and bandwidth thinking about where am I going to find that. And our SMS systems. We have an exceptionally robust safety management system, which is run by our pilots and one of our pilots in aviation. It's a completely open and transparent system. Every report that goes into it on both the clinical side and the aviation side is seen by everybody from the minute it goes in. And that is an open system that's followed up. Everyone sees the outcome of it. And there's pretty much rarely a day that goes by that an SMS or 2 or 3 aren't put in. So we have a healthy reporting system. We're always looking for ways to improve. We rarely ever have serious incidents. We have to look back a few years to find an actual serious incident, but we have such a healthy reporting structure, I think, or culture, that I think we're really dealing with all those, trying to capture those near misses. And that's part of the ethos of the organization. Governance is a concept I had to learn about when I went to the UK, because it's not something that we still really have embodied in healthcare systems in Canada in the same sense of clinical governance. And this is the definition of what clinical governance is, but really it's being held to account in a way that I've certainly never done as a healthcare professional, whether it was a paramedic or a physician in Canada, really going through all the things that we do. So this is basically the structure of our system, and so we have everyday rapid review. So we look at all the jobs the day before. We have set criteria we sort of quickly go through and see if we're how those are going. Anything from that we start off with a team debrief, I should say. So every job we debrief as a team, and we start to address issues and deal with them. We have a structured debriefing format. We then go on to rapid review. From that, jobs are highlighted if there's potential learning opportunities. That's either good learning or potentially bad learning. That go to D&D, which occurs twice a week. And this is the experience that you may have heard about in London, where at times in the past has been seen as negative, but you are asked to really go through and dissect every job and decision you make on a job. And when you're really sometimes critically said, so why did you decide to do this? How does like debriefing after a scenario, but these are real life jobs. And you really have to focus and be willing to and have a sense of being open enough to go in there to be potentially criticized, but also to learn and be willing to learn. And that's the type of people we select for this, and that's part of that sort of constrained, collective thoughts. We then go through to longitudinal audits and our clinical governance days, which are public and open, and anyone can come to them. So that we put some of these out so that our community and the people that we are held accountable to are able to see what we're doing. And then we have seminal cases that are just being developed. So this is part of a robust system that happens for all jobs, regardless of your level of stature in the organization. Certainly human factors and CRM you've heard about, but we train, and we do more of the, I know you don't like the term, someone low fidelity, high fidelity, but we sort of do the low fidelity kind of mannequins, but really emphasize the decision making and a lot of the other processes, the CRM process around it, more so than specific skills and procedural side of things, although we work on that in different ways. Every doctor and every paramedic goes through an induction course, which was for me the most difficult week of training I've had, whether it was in the civilian practice or in the military. They put you through your paces in a way that it was definitely, you find your limits, and that's part of the whole idea, so you understand where your limits are, and then once you've been there once, you know what it's like if you ever get close to that again. So that's a big part of it. Staffing is really interesting. So, and this is one of the things I think really makes this service work. So we have very few people that are actually full-time. So we have, it's mostly a couple people on the helipad. Our lead paramedic is full-time. We have a paramedic manager for the PRU, a paramedic clinician educator, and some support staff. I'm one of the only other full-time people there. I do about 70% research and administration and 30% clinical. And everybody else, all of our consultants, we have 13 consultants that are there, and the lead clinician who work about one day a week, and then we have senior paramedics that also come back on a 50% rota from the London Ambulance Service. And then we have two junior groups. We have doctors that come for 6-month rotations, as I call registrars, and then we have paramedics that come for now 12-month rotations in and out. And once you've done those junior jobs, you can potentially come back and do the senior jobs. But that in and out is good for a whole number of reasons. So in terms of training costs and burden and stuff like that, people maintain their skills in their day job. So if you're a physician, you're working in the ICU, you're working in the OR, in the emergency department, you're maintaining your skills, you're developing them, same with our paramedics. So the training and stuff that we get to do really focus on the HEM-specific training, a lot on the CRM and a lot on the team skills, as opposed to having to do maintenance of competency to make sure you have enough intubations this year and all that other stuff. Career development, certainly for the paramedics and for the doctors, but particularly for the paramedics, they find it exceptionally rewarding to come in and have an opportunity to develop their skills. Almost all of them then go through and continue to go up the ranks within the paramedic structure. One of the things that's developing in the UK, which isn't in London HEMS yet, but I think is one of the ways forward, because we have issues in the world, and particularly in the UK with retention and burnout and things like that in the paramedic world, but they have what they call rotating paramedics. So bringing people in and out of the clinical perspective into a specialist role and into hospital in the low practices. In some areas, they're starting to come into critical care and into the emergency departments. And I think that kind of system is ultimately what I'd like to see there. And they also have what they eventually call critical care practitioners in hospital, something like that, in hospitals, but they're basically in-hospital people that work in the ICU and intensive care environment. But it's a nice potential career progression for people who want to go through different pathways as opposed to purely being one role for their life. Certainly has an impact on culture. Having this constant movement of people in and out, it does keep it fresh. I think it really breaks down the us and them, because everyone in London Ambulance Service feels that the service is part of them. They could be in it one day, a lot of people go back and forth. It's not sort of the angels that come in and swoop in and save people. This constant in and out does that, as well as with the doctors in the hospitals. You don't have this us and them, because the person you're handing off into the emergency department may be the colleague who is on the helicopter the next day, because we have this constant in and out of the system. It also raises, I think, the overall level of quality of care within the ambulance system in particular, but also within the hospital system, of having people that go and get this high-end training and then disseminate back out and bring a lot of this with them. You get this trickle-down effect around the service. And it allowed us the ability to drive change much faster and really attract, for both paramedics and doctors, I'd say that some of the top talent, with obviously some exceptions that they let into the country anyways. One of the last things they did was that I think Gareth Davies in particular and Ann Weaver have done with this whole thing is they've created a profession of pre-hospital medicine. So they have a series of programs. So they have a pre-hospital care program, which is started at BARTS, and it allows medical students from their first year to start to partner. They initially go up with paramedics and different things with the ambulance service, and eventually as they get into the second and third year, the second clinical year, they come on with the PRU, and then the third clinical year, they're allowed to spend a couple of shifts with HEMS. But this gives them, even if they never go on and work in the pre-hospital setting, they have a respect and understanding for what people who are working in the pre-hospital system go through that nobody else ever does. So I think you see the relationship and the appreciation between in-hospital and GPs or whatever type of doctors they become, and paramedics and other pre-hospital staff differently. You can do a full year intercalated BSc in pre-hospital care, and as a bit of a plug, next year we're opening up our Masters of Pre-Hospital Care. If anyone wants to come and spend time in London, it's a distant learning course. You'll come over the 3 years a couple times every year for weekend blocks, 3 to 4 day blocks, which is always associated with a big training event. So sign up if you're interested. And then we run a whole series of courses for people from around the world in our Institute of Pre-Hospital Care. So that's really the why, what, and how of what we do there, and hopefully I'll entice you to come visit us someday and think about ways you may be able to incorporate